Thank you for having me. Sounds like you guys have a lot of good events coming up, and Fleetwood Mac is a great band, so yeah, I would attend that for sure. So today's talk is going to be about deep brain stimulation. I know most people here are probably not going to have had DBS, but it's still useful to know just what the reason would be to consider receiving it, and then what the process is like in terms of what you can expect during the process, and then what the different options are in terms of devices as well as locations for DBS. And then at the end of this, if you guys want to ask any questions at the end of it, it doesn't have to be related to DBS. If you want to ask anything just related to Parkinson's, that's fine. So what is deep brain stimulation? So this is a treatment that's been available since the 1990s, and it involves placement of electrodes that basically carry electrical current from a generator that's placed in the chest. And so there's, I guess, two separate phases usually with the DBS surgery. One is placing the electrodes themselves inside the head in the deep brain structures called the basal ganglia. And then there's another phase where there's a battery. It's basically a battery that's placed in the chest, and then there's a series of some connector wires that then transmit the electricity up to the brain. So there's stimulation of deep brain structures that improve the motor symptoms of Parkinson's. So this is an old device. It's the original Medtronic device. Medtronic was the first device manufacturer for DBS, and they still produce newer devices now. But essentially this just kind of illustrates the four different components of the DBS system. So at the top left has the pulse generator, which is the battery that delivers the electrical current. Then there's extensions, there's wires that transmit the electricity up to the DBS contacts, the leads that are placed in the deep brain structures. If you can look at the bottom left image, there's 4 contacts on a DBS lead. Generally this is, it's a bit different now, but 4 contacts basically allow the programmer to change the location slightly of where the electricity is, so that there's some room to adjust for maybe some slight error in lead placement. So generally the leads are attempted to be placed where the second from the bottom or the bottommost contact are going to be in the correct location, the sweet spot. But then there are additional leads to kind of just allow the programmer to slightly adjust the location if needed. And so then there's, you guys will probably have now it's like iPhone-like device that lets you, check the battery and check certain settings on the DBS, but then there's a separate device that I use for programming. So there's a couple of indications for DBS. We're going to focus on Parkinson's, but there's other indications for DBS. Is basically what I want to illustrate here. And the first indication was essential tremor. So I deal with, I don't really treat or do DBS programming for epilepsy or OCD, but I'll usually treat patients with the top 3 conditions here: essential tremor, Parkinson's, and dystonia. And so DBS is used for these 3 conditions. So who will benefit from DBS? So the point is that not everyone is going to necessarily benefit from DBS. So we need to decide, who will be a good candidate. And so the first, thing is that, you have to have Parkinson's disease and not an atypical Parkinsonian disorder. So there's some other atypical Parkinsonian disorders that kind of may mimic Parkinson's but are not actually Parkinson's. The actual disease pathology, what's going on in the brain is different. So so these patients don't respond to DBS. So that's the first thing. You have to have what we call just Parkinson's disease and not one of these atypical Parkinsonian disorders. And so typically people with Parkinson's will respond well to L-DOPA. Does everyone here know what L-DOPA is? Yeah, carbidopa, levodopa, cinnamate is the mainstay drug here for Parkinson's disease. And so the people with Parkinson's should respond to this. And so if you have Parkinson's and not an atypical Parkinsonian disorder, there should be a significant response here where it reduces your motor symptoms, namely the tremors, the stiffness, and the slowness of movement. Not everything gets better with L-DOPA, so there are some things that don't improve with this drug. Namely, it's the speech, the gait, and the postural problems. So that's, you have to take that into mind and kind of evaluate what are the main issues here that the person is dealing with, because if the symptoms respond well to L-DOPA, generally the patient will respond well to DBS. But then not everyone who has Parkinson's and responds to L-DOPA really needs DBS, right? So what would be the reason to do it? Like if you're taking L-DOPA and let's just say you're taking the starting dose, it's 1 tablet 3 times a day, then you're gonna not really require DBS. There's not gonna, and you're doing well on 1 tablet 3 times a day. Like there's no fluctuations in the effect of the drug over the course of a day, then you don't really have any benefit of receiving DBS. So people who will benefit from DBS are those who have lots of ups and downs with the effects of the medication, where the medication wears off frequently. Some people are taking it every 2 hours, and so even with every 2 hours or every 3-hour dosing, then you may feel like, well, the drug is wearing off before my next dose is scheduled, and then you're also waiting for the drug to kick in. It's it may not kick in quickly. It takes sometimes over 30 minutes to kick in. So then this period of time where you're feeling the drug effect is low, results in poor quality of life. And so then these are the people who really will benefit from the deep brain stimulation. So it gives you a constant or more predictable improvement in the physical symptoms. Another reason to consider DBS in the first place would be if the Parkinson's tremor just doesn't respond to the drug. So it is somewhat, I'd say, somewhat common where the slowness of movement may not even be that big of a deal. Some people just have really bad tremors, and you take all this L-DOPA, it doesn't make it better, right? So then when there really isn't, there are some other drugs that could be considered before DBS, but generally the DBS would be a good option if none of the medications are working for the tremor. And some people get lots of side effects to L-DOPA. The drug can cause daytime sleepiness, it can cause nausea, and so some people can't tolerate it well. And if you can't tolerate it, well, then that's the best medication, the best drug for Parkinson's that you can't take. So, and then the other drugs are probably not going to be sufficient. So I think then there's a relatively small group of people there who need DBS because they can't take the L-DOPA. So those are the main reasons that someone would want to get DBS. Now, the DBS surgery is generally pretty safe in terms of being a brain surgery, right? I mean, it is a brain surgery, and the neurosurgeon does implant, electrodes into the brain. They drill two, small holes in the skull, and then place these electrodes in the deep brain structure. So, there is, a risk here, but it's not a very great risk in comparison to other brain surgeries, because they don't actually, cut anything. There's no actual removal of brain tissue here. And it's just placement of electrodes into the central area of the brain here. So it's generally considered to be a relatively safe brain surgery. But if someone was in really poor general health or had dementia, then we wouldn't really consider this. It's more of a palliative therapy, in someone like that. And then also, if there's an uncontrolled psychiatric illness, there's been reports of DBS causing worsened depression and suicide in people with a history of psychiatric illness mainly. So it would be, definitely hesitate before doing it in someone like that. Generally, they do UCSF has like a psychologist who does like a neuropsych evaluation to just assess, someone's cognitive and psychiatric status before doing DBS. Okay, so this is an important slide here where I'm just showing you what's going to get better and then what does not get better with DBS, because a lot of people think that some of their main problems might respond to DBS, and so it depends on what the main issues are that you're coming to seek help with is. So it's mainly the tremors, the slowness, and the stiffness. Slowness is like the speed of movement, the time it takes to stand up from a chair, walk across the room. People with Parkinson's, might not, especially when the drugs wear off, have good enough movement speed, and so the DBS will improve that. And also the rigidity of the limbs, the stiffness, the resistance, with moving the limbs. This often makes using your arm, difficult because it's so rigid and stiff. Dyskinesia refers to involuntary movements. It's usually excessive movement. You can't sit still, and it's a side effect of the L-DOPA. So people with Parkinson's usually have the opposite problem, right? When they're not taking the drugs, it's the movement's too little, it's too slow. But if the drug is causing side effects, the carbidopa, levodopa causes side effects, it might cause this involuntary movement where you can't sit still. And then the movements are just everywhere. You cannot really control your movements well. And so it kind of, looks really embarrassing as well. It's like, what is this, person doing? But the dyskinesias usually are only kind of there when someone's getting lots of fluctuations in the effect of the L-DOPA. So the L-DOPA tends to wear off earlier than expected, and then when it does work, it causes the involuntary movements to occur. So if it's mild, and I tell people there's no reason to do DBS or even treat dyskinesia if it's mild, and it's just kind of like a social embarrassment. But if it gets really bad, where it's like you can't sit still and falling out of a chair, then then it needs to be treated. So those would be those are what we call the motor symptoms of Parkinson's, and these physical symptoms respond to L-DOPA and respond to DBS. So in general, the symptoms that respond well to L-DOPA will improve with DBS as well. Now, what doesn't improve generally are are speech problems, the soft speech, trouble swallowing, and really the gait and the balance problems, don't improve much. The cognitive symptoms in Parkinson's are usually not like memory loss, and they don't, develop like Alzheimer's, like, memory loss in Parkinson's disease. But there are other cognitive issues, that generally will not, get better with DBS either. So. All right, so this is a graph, and I just wanted to show this because, I like showing some graphs in my talks. And this was actually a paper that was published by one of my mentors at my fellowship program in Oregon. So basically what he did was he implanted DBS in this one patient here who had Parkinson's disease, and then he basically measured the tapping rate. This is how fast this person can tap a plate, and then the total number of taps are measured. The L-DOPA is being given at certain intervals here that you can see from like the top of the, you might not be able to see it too well because it's small up there, but anyway, there's arrows that point to when the L-DOPA is being given, and those generally correspond to like the lowest tapping rates, because this is when the drug is, mainly out of the system. So the dashed line shows this kind of peak and then drop, and then trough and peak and trough, where the patient is receiving benefit from the L-DOPA, is able to tap the plate really well when they're at their peak, and then in the trough, then the L-DOPA wears off, right? And then this patient is pretty much frozen. It's like, the tapping is so infrequent that there's barely any taps occurring. But then they get the DBS and they turn the stimulation on, and you can see that when the L-DOPA wears off, like the second half, you can still see some troughs here, but the troughs, are not anywhere near as bad as without the DBS. So the worst state here, like when the drug wears off, is still going to be like very good. It's going to be almost as good as with the DBS on, or when the DBS when the L-DOPA is working. I mean, so you can see that it's pretty comparable, right? With even no medication in the patient and DBS on, it's pretty comparable to drug on. And then they get a little better, with taking the drug as well. So it pushes them to a better state than without the DBS. But the DBS in general, and the right graph kind of shows that the DBS, when it's turned on, is pretty similar to the maximum effect here of the carbidopa-levodopa. This patient got an infusion, so we don't do infusions, in the clinic here. They just did this for research, but it kind of shows that the L-DOPA goes directly into the blood, and therefore it's able to be absorbed the best into the brain. It doesn't suffer from any oral pill absorption issues. So it just shows that this L-DOPA infusion produces the best effect that the patient gets from the drug, and then it's similar to the effect of the deep brain stimulation. So. All right, so you guys may not be able to read this, but I'll just kind of describe. So the DBS surgery generally is pretty safe here, but 1% of patients have been reported to have brain bleeds, and this is the worst complication from it. And so if a brain bleed occurs, there's nothing to do, right? Then you might have depending on the severity of the bleed, you might have like a serious neurologic deficit as a result of it, and some people have died from it. So there is a low risk here of a serious side effect here, and then there's about a 3% risk of infection of the device, and that would require the device to be removed. And then there are some other kind of like stimulation-induced side effects. It's like, if you ramp up the stimulation, you might cause like this involuntary contraction, one side of the body. And so it's like this body, your whatever side is being treated, might develop like this involuntary contraction, and it's very uncomfortable, right? But as long as you lower the stimulation afterwards, this happens, then it's not going to be. I'm not going to send you home like that, right? So, then it's a temporary side effect, from the DBS that is related to the basically the spread of the current away from the targeted structure. So, when to perform DBS surgery? Well, generally it's as soon as these motor fluctuations interfere with quality of life. So, generally there are ways to like treat motor fluctuations as well just with pills, right? They're usually advancing the formulations of carbidopa, levodopa. Now there's a new formulation called Crexont, that's going to be better than Rytary, and can provide a longer lasting benefit from the carbidopa, levodopa than previous formulations. But so there are ways to try to treat these fluctuations just with pills and not do DBS. But I think that it generally will just improve someone's quality of life faster if we do DBS when this becomes a significant problem. And so it's like, if I've changed medications a couple of times in a year, then it's definitely worthwhile to consider DBS rather than kind of, try to make more adjustments that, may not be effective. So, I wouldn't do it if you've been on the stable dose of carbidopa, levodopa for a couple of years and everything's fine, right? Then there's no reason to do DBS. The medication may not make all your symptoms go away, right? And you might still have some tremors that break through and trouble moving, like one side, of your body. But as long as the medication provides a 50% benefit or more when you take it, then we would kind of consider it working here. And as long as the effect remains, consistent, over the course of the day, there really wouldn't be a reason, in my mind, to even do DBS. So it really needs to be kind of like, okay, well now all this wearing off the drug is really affecting my quality of life. Then we would consider it. There's no absolute upper age limit. You could do DBS surgery in an 80-year-old. If there was minimal gait, balance-related problems, and so given that the gait balance problems don't really improve well with DBS, and people who are older are definitely going to have more of that than people who are going to be, in their 60s. Generally, there would be a better, better indication for someone to receive DBS who's, earlier, younger, but even an older person could still get it. And then prior to development of dementia, dementia is kind of just a term here that means, well, the cognitive symptoms are preventing you from kind of taking care of yourself. So in that type of case here, we wouldn't really do it. Generally, I said 4 years after symptom onset, wait 4 years after symptoms have started to perform DBS. The only reason to do that is so I'm kind of certain that you don't have an atypical Parkinsonian disorder, that often like really early on may look like Parkinson's, but then later on kind of looks different, right? Looks different and looks, worse than Parkinson's. Okay, so if you're a good candidate for DBS surgery, I've listed some other things to consider. And so number one is they can do the surgery, the neurosurgeon can do the surgery either awake or asleep. So historically, it's been done mainly awake. And so what this means is that they wake you up from anesthesia and basically have you do some movements, to make sure that when they stimulate the DBS lead and have you do some movements to make sure that the lead is well localized and is effective at treating the speed of movement or the tremors. And so this is, the way to do it to ensure that the lead is well placed. And so that's the main benefit of doing it in awake surgery, is that you can kind of verify, okay, well, I placed the lead here and now it's being stimulated and now the symptoms are getting better. So, but the problem with awake is that, it's sometimes fairly traumatizing here for patients to be woken up here, and have a surgery that's underway. And also you have to be off of your medications in the morning. So you get there to like the OR, you're off your drugs, and so you don't feel good when you arrive to the OR. So that's but the awake surgery is probably the kind of default method to do the deep brain stimulation. There's also an asleep method as well. This kind of just uses the imaging, like the CT and MRI scan, to like localize where the target is, and then it verifies that the lead is placed anatomically in the correct location. And with this, you just kind of, you can take your medication in the morning of, you just go to the OR, and then you're asleep for the whole thing, and you wake up and it's done. So that's the benefit of the asleep. Actually, I have another slide where I'm going to go into that in a little more detail, but these are just the questions that, are worth considering here if you're going to get DBS. So then the other question is, where should the leads be placed? There's 2 locations that I'll go over, and then what type of DBS device should be received. So there's 3 different device manufacturers. 2 of them are used commonly in the Bay Area. All right, so yeah, this is the slide that basically kind of just gives the pros and cons of awake versus asleep DBS. So the asleep DBS hasn't shown any worse outcome than the awake DBS, but the awake is able to kind of verify that your symptoms are getting better right there in the emergency department, or in the OR, excuse me. So what location is superior? There's 2 different locations. There's subthalamic nucleus, which is abbreviated here as STN, and there's globus pallidus, which is abbreviated as GPI. So there's 2 locations for DBS and Parkinson's. For the most part, they're pretty similar at treating the physical symptoms. So I think, even if you didn't know, hey, what location you wanted to get here, if you got either of these, you would get, improvement in your motor symptoms. But there's there's 1 or 2 things that will be different based on the location of the DBS lead. So the globus pallidus is best if you've got really bad dyskinesias with a low dose of carbidopa-levodopa. So like a low dose is like you're taking 1 pill or less with each time that you take it, and it causes the involuntary movements, the dyskinesias. Well, then when you get the DBS, you're not going to be able to stop your carbidopa-levodopa. So if you had the other location here, the subthalamic nucleus, you're probably still going to need to take the carbidopa-levodopa, but then you also have the DBS, stimulation occurring, and that heightens the dyskinesia. So then the dyskinesia gets worse. So so the GPI is better if that's a problem, if you have bad dyskinesias, because the GPI will the stimulation of it will actually reduce dyskinesias. But the subthalamic nucleus generally is considered to be more effective at lower current. So you require less electrical current to treat the motor symptoms, and so and get a significant improvement. So it's considered to be probably better in that respect because you don't have to stimulate as high. But the GPI generally causes few side effects. It's a much larger area. This structure is larger than the STN, so if you get spread of the current with higher stimulation settings, then it's probably not going to cause as many side effects as if you had the same current over stimulating the STN. So for that reason, they're both fairly comparable. So STN is the little yellow bean here, and the GPI is the big pink like fava bean, I guess is what that is, right? And so the GPI is bigger, right? That's what this is illustrating here. It's like GPI is a bigger structure, and the STN is a small structure. But the STN is better if you want to reduce your medications. That's the main. And also if there's not a reason to do the GPI, I would just kind of default to the STN because it's probably more effective at lower stimulation settings. So the STN is preferred in those situations, but the GPI is better if you have bad dyskinesias. And GPI is also associated with less like stimulation-induced side effects. So there's a couple of devices here. So I've listed 3 of them. Once again here, just kind of like location, like all 3 devices are probably going to be fine. So, they've got 3 different device manufacturers, and they've all got kind of their own thing, but they all will, provide the necessary benefit, to improve here. But it's worth kind of going over, what each of these device manufacturers does. There are some things that might influence the decision on what device to get. The first thing to note is that they all have, what I think are like the most important. The most important things here are they have these directional leads. Directional leads are new in the last decade, and basically they allow the stimulation to be. So each of these contacts on the DBS has 3 different components. Instead of stimulating the entire contact, they've got 3 separate components on each of these contacts. So they call them directional leads because like one's in this direction, another goes in that direction. And so basically you can just turn 1 of the 3 on, you could turn 2 of the 3 on, or you can turn 3 out of 3 on. So it gives a little more control to the programmer to kind of determine, hey, do I want to just stimulate part of it or the whole thing? Stimulating the whole thing, all 3 of them, is equivalent to stimulating to what was done before they had directional leads. So there's no downside here to these directional leads. And every single device manufacturer has that now. It used to be Abbott, that was the first one that had it, but then all of them have it now, so it doesn't really, that's something that they all have. Then all devices have rechargeable and non-rechargeable batteries. Rechargeable basically means that, the battery's gonna last a decade, but you have to recharge it. You have to sit down and put this charger over it every couple of days, usually is sufficient here, and remember to recharge it. So it's like recharging your cell phone, right? If you forget to recharge your cell phone, the worst thing that happens is your phone dies. But if you forget to recharge your DBS battery, then then the DBS dies, right? And then that's bad. And also these rechargeable devices. If you drain the battery completely and it dies, then that diminishes the overall battery life. So they have these non-rechargeable batteries, which are for people who don't want to have the fuss of recharging it. It's kind of up to you what you prefer. The non-rechargeable needs to be replaced every 3 years, while the rechargeable, as long as you charge it up, will last 10 years or more. Then all devices are MRI compatible. So if you need to get a brain scan or MRI of the spine, you can get it with any of these devices, but you may have to either turn it off, or you may have to have like a certain setting that is allowing the MRI to be performed. So there, you just have to check with your doctor to make sure that you've got the right program that for an MRI, or to turn it off before the MRI scan is done. But you can get MRI scans with this metal device here. And so, all right, so Medtronic is they're the first DBS manufacturer. They're the originator of DBS. So that's why I'm talking about them first. So they have this what they call Brain Sense Adaptive DBS. It just came out, so still kind of figuring out how to use it, but it is able to analyze brain signals, and then it can automatically adjust like the DBS settings. So it looks at these these brain waves, and then it adjusts the DBS setting based on a certain range that I can set here to either stimulate more or stimulate less. And so this allows for better motor symptom treatment over the course of a day. And also they have this identifier, it's fairly convenient, where it just kind of like shows you, okay, this is the best lead, right? This is right here. I just load up the screen, and this is the best lead. It shows me right there. And so then I don't have to like test out, multiple leads. Usually, the first programming visit is like I'm testing out the leads and figure out which one's the best. And this is time consuming and maybe uncomfortable, right, to do this. So that's what Medtronic has, but this just came out. And then the Abbott device has a very small battery. So this DBS battery is extremely small. It's not very noticeable. They have a very long-lasting battery charge for their rechargeable device. 37 days is what they list on their website. And then they also allow for this virtual programming. So you can do this remote programming if you live far away from the clinic. The doctor can log in remotely and adjust the settings remotely. So Abbott has that. Boston Scientific has this map that they show on my screen. Like I have like a tablet, and then shows like a map of your brain, with the Boston Scientific device. And so then it shows where the lead is, and then where in the brain the lead is located. So, and then it shows me like, okay, well, this is the targeted area there. It shows where the current is going. So I can kind of like, as I'm programming, I can say, okay, well, this is pointing the current in the targeted area. So it's supposed to help with the programming. It's essentially what it does. It helps me program the device so that the current is likely going in the correct area. So it's a software thing that helps and provides I would say mild significant benefit on the first DBS programming visit. Once the device is programmed, you're probably not going to need any like frequent reprogramming, for a while. Usually we just kind of follow up, routinely, every 4 to 6 months, but there may not be any like reprogramming needed, at follow-up visits. So generally after the first visit, you may not need to adjust anything. So this is all kind of just this is all, the Boston Scientific map is useful on the first visit, but once you get to the right setting, then it's no longer really used. All right, timeline of what to expect. So the first thing is you need to make sure that you're a good candidate. So you have to demonstrate that the L-DOPA provides a significant benefit in the symptoms that need to be addressed. So you come in off medication to the clinic, and then you take your, I do an assessment, I do a examination, and you take the pills, you wait for it to kick in, and then if it, once it kicks in, you do another exam to ensure that the, that the drug is providing a significant benefit that then, would translate to benefit from deep brain stimulation. So that's the first thing. Then after that, there usually is neuropsych testing. Neuropsych is, there's a neuropsychologist, a PhD psychologist who then does a cognitive assessment. And this is often done prior to DBS, because of some cognitive or psychiatric side effects that can occur. And then the third is the placement of the leads by the surgeon, placement of the generator, and then the final step is after, like a month after the generator has been placed, you come in for the programming. The first programming needs to be off medication, so you come in off medication, we turn on the DBS, and then see what the benefit is. If you're getting a good response to the DBS, then you'll take the drug the same day, wait for the drug to kick in, see if there's any issues with both the DBS and the drug working, and then if not, then you go home. The second visit is on medication. You take your drugs, and then I see what effect the DBS plus the medication have together. Okay, so that's it. Hopefully that was useful for you guys. And so, yeah, why don't I take questions? And this was a DBS focused talk, but I'm willing to answer any type of question as well. So, yeah.
2 mics.
I think you might ask everybody here who has had DBS. How many people here have had DBS?
So about 4, okay. 5 maybe, is it someone about 6?
Were you surprised at that reply?
I think that, DBS is a very effective, treatment here, and I often will, recommend it, right? But there's a lot of, fear about getting brain surgery. So, and I understand where that's coming from, right? It's like, you're going to get, this hardware, placed in your brain and your body, and so that's, I think, what generally, detracts most people who are otherwise good candidates from getting DBS. But I'm just trying to illustrate, what the result of the surgery would be here.
My family has had a great deal of experience with DBS. My wife, Sue, has DBS. Both my children have had DBS, all for longer than 10 years. We carry the LARC2 gene, and we were friends with Earl Bakken in Hawaii, who developed the DBS device. So our time frame and experience with DBS, unfortunately, is a great deal longer than most anybody else. And it has been very positive. Sue charges herself at night. It takes like 8 minutes when we're watching television. And it is no big deal. We've had very successful results from DBS. And I detect a certain hesitancy in your recommendations that I would be aware of our successes. And it seems like it was a very good decision.
Okay. Yeah, good. Thanks for sharing that. Yeah, I mean, I think it's a very good surgery, and I do, recommend it often. But there are some, some things to consider for sure, about DBS, and I just want to, make it clear that not everyone is going to benefit from it. So you want to know, who the ideal candidate is.
Has there been any ongoing research on gait? That's the problem I'm having.
Yeah. So, okay, so freezing of gait. What do you have exactly? Is it imbalance or is it freezing of gait?
I have imbalance, but I get happy feet and then I fall.
So this stutter stepping, issue here, is very difficult to treat. And so, this is one of, I'd say, the main issues in Parkinson's disease, and we need better treatments for that. So, I hear where you're coming from. The DBS doesn't generally improve that too much. Physical therapy is kind of the mainstay of treatment for that.
Back here, Dr. Way. On your slide, when you describe tightness as something that improves with DBS, when patients describe that, does that tightness fluctuate, or is it a feeling of tight muscle that's constantly there?
So basically, like when I say, rigidity, it's that, the limb is difficult to move, right? So I'm moving it myself, and there's a lot of resistance in moving the limbs. And then this translates into the, difficult, the patient having difficulty in actually using it. That does get better. Like the limb will be less stiff, it'll be easier to use, and will be more functional. It may not, instead of it being stuck to the side, when someone's walking, you might be able to swing it better.
Dr. Way, did I understand you correctly? Does DBS, is it only done on one side of the body? And if that's the case, does Parkinson's affect both sides, or?
So it's not only done on one side. There have been some people who only do it on one side because they only have one side of their body that needs it. But generally, it's done on both sides of the brain. And so most people would get leads placed on both sides, because Parkinson's is not going to be usually just affecting one side of your body. Yeah. Now there is, I didn't talk about focused ultrasound, but there is a more recent treatment here called focused ultrasound. And let me just spend maybe like a couple minutes on that. So this is done over at UCSF, and what it involves is they can put your head into like a very rigid frame so that it doesn't move, and then they use ultrasound waves to target a specific region of the brain. They gradually increase the intensity of these waves until it causes a lesion. A lesion means like an area of destruction of brain tissue. And so then this lesion results in improvement, of some symptoms, and mainly it's tremor. So the main reason to do it is tremor, but it basically just targets one side. So if you've got tremor that's really bad on one side, then it's worthwhile to consider that. But it's not really used to say, hey, you're not moving well, you're slow, and you're stiff here. Well, the focused ultrasound for Parkinson's is not going to be really as good as DBS in treating the slowness here. So it's mainly for tremor.
Hi. You had mentioned 3 different devices, including Medtronic, Boston Scientific, and another. I'm wondering if you would consider one of them more advanced, and if there's one that you prefer, or is it all entirely specific to the client?
Well, are you a DBS rep? I don't think they're here right now, so.
Do they call you a rep?
What's that?
Do they call you a rep?
Well, in the Bay Area, mainly, we do Boston and Medtronic. So those are they did a lot of Abbott in Oregon. So I trained in Oregon, so I know it. But, out here, it's been, Boston and Medtronic. There's a lot of interest in this very recent adaptive DBS for Medtronic. So Medtronic might be taking the lead now, but I mean, up until now, I mean, Boston was really the better in terms of the this map that they had, that helped with programming. So I'd say now maybe Medtronic is getting to be the best.
Dr. Ray, this is brain surgery. What is the typical recovery time for this?
Yeah, so actually, all that's really done is, you get the DBS surgery, then you stay overnight in the hospital, make sure that, you haven't had basically your brain bleed, right, from this. And then you're discharged the next day. So it's pretty easy.
As a follow-up to the gentleman that had the fascination, the freezing at gate, is that a big issue, or do you already have it?
Yeah, the freezing is, I would say, the most, bothersome issue for a lot of people here. And, the DBS isn't really going to help that too much. So it's one of the main struggles with Parkinson's, and we really need a better, treatment for that. What I generally do is, I would try to make sure that, the dose of the medication is sufficient. So you may have to increase the dose of the carbidopa levodopa here to ensure that you're getting an adequate dose that would likely improve the freezing. And then, so there might be a period of time where kind of increase the dose to see if you respond well. And if the L-DOPA improves the freezing, then you're in luck. But there's a lot of cases where the freezing just is not responsive to that, right? So.
All right, I have time for one more.
I'll hang around too, maybe afterwards if you guys want to come find me.
How do you have to modify your exercise schedule with the DBS? Is any exercise dangerous, like rock steady boxing or resistance training, lifting weights?
Yeah. So I mean, there are these contacts. There's these connector wires in the neck. Now, I've heard of a case, but I've never had a case myself where these actually got fractured. So, for the most part, you can do any type of exercise, and we don't really get, people who are lifting extremely heavy weights, after they have DBS, but you can definitely do, high intensity interval training type of workouts that will not disrupt the device. Yeah.
Hi. Will acupuncture, in addition to exercise, help reduce stiffness and range of motion?
Did you hear that?
Yeah, the question is, will acupuncture reduce stiffness and improve range of motion? Well, I don't think so. And so I haven't really studied alternative, treatments. Or I know about some. We get people who come in from see naturopaths, right? And so these are the type of doctors who would recommend acupuncture. I get some people who have seen naturopaths, right? And so they tell me that they find it helpful, but I don't think it's evidence based. And so based on having evidence from scientific studies, right, to back up treatment recommendation, I don't think acupuncture has that.
Thank you, everybody. Thank you very much, Dr. Wei. I think that was really